In the past 5 years, there has been a veritable explosion of new drugs and technologies to treat diabetes. So what is the difference between type 1 and type 2 diabetes? What are these new treatments and technologies? An expert in this field will address these questions on this week's Health Talk. We're up next. Hi, today we're going to discuss diabetes with Dr. Nancy Rennert. She's Chief of Endocrinology and Diabetes at Norwalk Hospital and also a good friend. Welcome back to Health Talk.
Thank you.
So good to have you. This is an area, diabetes management, used to be pretty simple when I was a resident, and now it's become very complex. What's going on?
Well, you know, we have so many options now, and there's been really, as you mentioned, an explosion in new medicines available and technology, so there's just a lot of opportunity for us to help people.
It's funny because, you know, we sort of learn that diabetes is a relative or absolute deficiency of insulin, but now it's become much more complicated with many more drugs and pathways involved. Maybe you could say a little bit about diabetes. What is the difference between type 1 and type 2? And then maybe move on to our understanding of the bigger picture of diabetes, which has allowed all these new therapies to come into play.
Sure. So as you know, classically, type 1 diabetes was thought to be autoimmune, where the body is making antibodies against the beta cells, which are the cells in the pancreas that make insulin. It often occurred in childhood and often occurred very suddenly. Type 2 diabetes.
So this isn't something you're necessarily born with then, this type 1 diabetes. Right. It's an unfortunate consequence of a viral infection or something else like that.
Yeah, and that was the classic teaching. And then on the other end of that was type 2 diabetes, which is thought to be more of an issue with being resistant to the body's insulin and not having enough insulin to do the job, which is often associated with obesity and occurs later in life. However, this sort of binary distribution of type 1 and type 2, we have a much greater understanding now, and it appears to be that there's much more of a spectrum. So sometimes we call it type 1.5, or we might you know, sort of say something in between, but the issue is that older people can develop an insufficiency of insulin, and we do know that even classic type 2 diabetics, if they have their diabetes long enough, the beta cells essentially are not able to produce insulin, so they act just like classic type 1.
So interesting. I learned that, as you said, type 1 is an absolute deficiency of insulin. You don't have beta cells. That's pretty straightforward. Mm-hmm. That with type 2 diabetes, at least early on, because of insulin resistance, the body has to produce excess insulin. So there may be high insulin levels, and then you can beat on the beta cells only so long and they begin to wear out. Is that still a fair way to describe it? Or are there people that are never able to bump to the insulin
Well,
levels?
I think we have a more holistic approach. So there are some people that don't exactly fit those definitions. And we do know that over time, even those folks, as you mentioned early on, who can boost their insulin levels with medication or just do it naturally, over time those beta cells essentially become dysfunctional and they're not able to do it. So with people with type 2 diabetes, even classic type 2 diabetes, if they live long enough, all roads lead to insulin because they can't make insulin.
Can we say also, I think with some of the bariatric surgery, the weight loss surgery, we've also seen the curing of type 2 diabetes by weight loss. Maybe you could say a few words about that.
Well, you know, and that's a very interesting thing. And recently, there are data that are published that show that actually bariatric surgery is a very good treatment for type 2 diabetes. And the most interesting part to me is that you think, okay, yes, weight loss, but the insulin requirements go way down before they lose weight. So it's really immediately post-operatively. And it's thought that this may have something to do with the changing of gastrointestinal hormones, but it's not exactly clear.
So we know actually the GI hormones, other than insulin, also play a role in diabetes.
They do, and it's been an area in which we've been able to target drug therapy. And maybe this is a good time actually to
bring up that slide.
Yeah.
It's going to look complex, but I think for our viewers at home, it's really to help us understand how complicated our understanding of diabetes really is. So Nancy, walk us through this slide.
The point of this slide is that, you know, most people will think of diabetes and think about the pancreas where insulin is made. But in fact, there are many body organs that are involved with diabetes, including, as we just talked about, the gastrointestinal system, the liver where glucose is made.
And actually, you're going counterclockwise around this this diagram. So the pancreas is at the top in
Yes,
yellow.
the pancreas at the top. Then, as you said, counterclockwise would be the intestinal system, and then the liver, and then the kidney, the fat cells, the muscle, and even the brain is involved. So, so many organs are involved, and this has given us great potential to be able to find new medical therapies, because we can then target any of these areas and then use these various drugs in combination to make them more powerful.
Could you give us some examples while we're looking at this of some of the new targets?
Sure. So one of the new targets that is on the gastrointestinal system and is listed on this slide is the GLP-1 agonist. That is glucagon-like peptide 1 agonist, and these are naturally occurring hormones in the gastrointestinal tract. This is a class of medications that is injectable, can be given once a day or even once a week. I can actually show you. No, don't do. Okay.
Okay.
So, so they're given once a day or once a week, and this is an example of the pen that is used. And here's another one. These can be used with insulin or with other medications, but that would be an example of.
Now, I thought glucagon raised blood sugar, and these are glucagon agonists.
Yeah, so what they actually do is kind of what you want them to do. What they'll do is they will increase insulin, decrease glucagon, and they actually also promote satiety at the level of the brain.
I see. So they're really acting on the insulin part and on satiety, not on mimicking glucagon action.
No, it's actually limiting that, right?
Okay.
And it works very well with insulin and also with other oral agents.
Because people would not realize that at home there's insulin, and then I was taught glucagon, and they sort of the opposite effects on blood sugar.
They are, yes, and glucagon is what we call sort of a counter-regulatory hormone. So it does have the opposite effect. It would bring the sugar up.
Okay, so these mimic, and I know there's an awful lot of advertising about these agents on TV.
Yeah.
Maybe you could say a few words about that, because I, as a patient, I would think I'd be overwhelmed by the different insulin or non-insulin treatments and all the direct-to-consumer advertising that's occurring.
Yeah, I think, you know, today I think people want a lot of information, and I actually in many ways support the direct-to-consumer advertising, because I think it brings, it allows patients to bring questions into their caregivers and perhaps to bring new ideas to the table. There are many different drugs in each of these classes, but at least getting the information out there is helpful, because most of diabetes are taken care of in primary care, and I think knowledgeable consumers, knowledgeable patients, it's a very important thing.
So we've talked about the liver there, the glucagon, or mimics the glucagon-like peptides. There's something called incretins in that area too. Tell us how that fits into the.
Yeah, so the incretin mimetics are pills, not injectables, and they have a similar mechanism of action, though not exactly the same. They do tend to be a little bit weaker in terms of how effective they are at lowering the sugar, but they can be useful as well. Another class that we haven't talked about yet, but is a newer class, are the SGLT2 inhibitors. And these work on the kidney, which is one of the organs that also does make glucose, the liver being the major one, but it is the major way in which glucose is excreted through the body.
So this causes you to dump sugar in your urine.
It does.
And that's why they're associated with urinary tract infections and yeast infections.
That's true.
Because sweet urine, things like to grow in it.
That's true. But the interesting thing about those are that at least one and probably two medications in that class have been associated in recent studies with lower heart disease in patients with diabetes.
Once before we get further into these are all new drugs, they're patented, they must be very expensive. Does insurance cover all of them? Is there a new burden now on our diabetes patients financially?
Well, they are very expensive, but each of these companies does have an indigent program, so they do help with that cost. There's a lot of coupons and discounts and things online, and I have found in my practice that I'm able to help patients to afford, even those who don't have any insurance. We can often allow them access to the newer agents, because there really aren't that many that are generic at this point.
Yeah, and I think part of the advertising is that they're all on brand now. Now,
Right.
the liver was there, and I know the drug that that affects the liver and sugar has been around a long time and is really a staple now of diabetes therapy.
Yes, that would be metformin, which primarily acts to decrease that glucose production, which is a function of the liver. It has been around for a long time. It is generic. And in all of the different published algorithms and guidelines, it is generally the #1 suggested starting place unless the patient couldn't take it, which would be primarily because they had significant kidney disease. So it's a good starting point.
And then some drugs are going out of favor that used to be used for diabetes therapy. The drugs called, I guess, the TZDs or the glitazone, rosiglitazone and others. Maybe you could say, and also some of the sulfonylureas, if you could say a few words about both of them.
I think as we've developed...
That's when I sort of stopped treating diabetes.
Right.
Is when we use those.
Yeah, that's an old one. As we've developed a lot more classes of medications, we're able to balance the efficacy and the side effects. And the issue with the sulfonylureas is that they cause low blood sugar, which can be a problem if the patient doesn't eat. And also they cause weight gain. And many of our patients, especially with type 2 diabetes, struggle with their weight. And also they, at least in the setting of having an acute heart problem, have been shown to have some negative consequences. For the glitazones or
So does that mean, to a large extent, you're not using those drugs at all?
No, I don't use them, really.
That's it. So they're pretty much off the table today.
Pretty much.
If someone's taking them at home, or a glipizide or something like that, should they continue taking it?
Well, it does work for some people, and if they're not having any of these side effects, then it may not be necessary. You have to look at each individual case. But in terms of starting new therapy, it's not generally something we do. First, we generally would go initially with metformin.
That's because they used to be the dominant therapy. And how about the glitazones, the other that were supposed to improve insulin sensitivity at the muscle level?
Yeah, I
and
mean,
seem to be such a smart way to treat diabetes.
Yeah, I mean, they really, sort of theoretically have a very cool idea about decreasing insulin resistance. When they got into practice, it became obvious that there were some side effects of swelling in the ankles, and even some cases of heart disease that weren't present before. And so one of the agents in that class, Avandia, has been, rosiglitazone, has been essentially, it's still on the market, but there's a lot of warnings about using it because of the cardiac effects. There's another medication in that class that still is available for prescription, but I think most of us don't use that as first line. In addition, they are very expensive, and they do tend to cause weight gain as well.
Really amazing. Well, so really not only new agents, but a transformation in the way we use these agents. We're going to come back and talk a little bit now about the devices, but that's all we have time for this segment. So I want to thank Nancy and come back after this short break. Hi, I'm back with Dr. Nancy Rennert, expert in diabetes endocrinology. We're talking about sort of a massive change in diabetes medications and therapies. Anything else you want to say about how do you choose about, you said for most diabetic patients, I'm sure weight loss and exercise, you do that.
Right.
First drug is pretty much agreed for most people would be metformin.
Right.
But then you've got this array of SGLT2 inhibitors and et cetera. How do you choose among them?
Well, that's a very good question, Eric. At this point,
we choose to refer patients to you. That's how we get around
right.
it.
So what we really need to do is to personalize that. We look at a number of different factors. There currently aren't any studies that show us sort of a stepwise approach how to do that. So what we do is we really think about that individual patient, and we consider a number of parameters. For example, we might consider how long, for our type 2 diabetics, how long have they had their diabetes? As I mentioned before, initially there's an excess of insulin, but as time goes on, there's a lack. We might also, there's two types of insulin secretion that occur naturally, and two types of glucoses or sugars that we ask people to check. The sugar that occurs at what we call the baseline or fasting, and the sugar that occurs after you eat. And so we may look at one or both of those and target a medication that will affect whichever one of those we're looking to do.
Do some of these new drugs preferentially affect post-eating or postprandial blood sugar levels?
Yes, they do. They do.
Which ones? I didn't know that.
Well, for example, the GLP-1 agonists will affect both fasting and postprandials, whereas the longer-acting agents like metformin is primarily affecting a fasting level.
And let me ask you, I know one of the big risks using some of the earlier anti-diabetic agents and insulin is low blood sugar, hypoglycemia.
Yeah.
Are all these agents have a much lower risk of hypoglycemia?
Yes, and thank you for asking that question too. Pretty much other than the sulfonylureas or there's another medication that will cause an increase in insulin secretion, but the rest of them do not cause low blood sugar. Most of them also, with the exception of the glitazones, don't cause weight gain and actually may cause a little bit of weight loss. So they're much more favorable
in people
in
with
that
diabetes.
regard. Yeah.
Now, we do want to get to some of the technologies, because not only has there been a revolution, an explosion of new drugs, which is really giving you a lot more nuanced approach to treating diabetes, but we have a table full of devices here that have come out of new technology. Walk us through some of your favorites.
So the technology has been absolutely amazing. We are able to see things and have an opportunity to manage things that we never had before. So as an example, we have continuous glucose monitoring systems. I'm showing you two of them here. They're very small, you can see, and what happens is they have a little tiny catheter, plastic catheter that sits right underneath the skin.
You know, and I've seen that just for people at home. It looks like it's about the diameter of a thick needle, maybe a safety pin.
Yeah, and it's not sharp either. It's just a little catheter.
No, that's how small it is.
Very small. It doesn't go into the blood. It just sits right under the skin.
And sometimes people think of catheters going in the urinary tract. By here we mean a catheter that goes through the skin and sits under the skin.
Right. It's very small. And what it does is it's actually measuring the sugar or glucose of what we call the interstitial fluid. So it's not going as deep into to get to the blood. But the cool thing about it is that you can keep track of the sugar every 2 to 3 minutes over a period of time. They come in.
Can I ask this, because I just think about what people will think. Does it hurt going in? Does it hurt while you're wearing it?
It doesn't hurt.
Or is it so small that you just don't?
It's so small. I mean, it hurt many people. It hurts less. They say it hurts less than checking your sugar with a lancing device in the finger. So and then when it's sitting in there, people don't even feel it. And these particular ones would need to be changed every few days, but there is one that's coming out very soon that can go for every couple of weeks. They're used two ways. They're used diagnostically, so that the clinician can have a printout of what the patient.
So do they broadcast to that measuring device?
So what this does is this basically allows you to control it and to put in data, and then what you do is you download it to a computer, and you get all kinds of graphs you can imagine, and you can analyze exactly what's happening. So for example, one use would be if someone is waking up at night with low blood sugar, they can wear this, and you can determine from checking their sugar every 2 minutes exactly when that's happening, and then you can adjust your therapy, particularly if they're on insulin.
So when a patient brings one of these into you, you can actually put it into a computer and get a graph of their blood sugar during the day?
Exactly. And then some patients who do have these, they have a patient model which allows them to actually see their sugar.
Just again, for viewers at home who may remember the days when you measured urine sugar, which was a very
this is a step up.
This is almost like what the body's doing.
Yeah.
In terms of at least being able to measure the blood sugar in an ongoing way.
Right, it's very cool. And so anyways, these also have been linked to various insulin pumps.
That was going to be my next question. So you can actually, and that's almost what an artificial pancreas is supposed to be, is
well,
it
you
not?
know, we're definitely on the road to developing an artificial pancreas. It's done in stepwise fashion. Now these current insulin pumps, so what an insulin pump does is it is continuously delivering insulin, and you program it.
Do you get a choice of colors with the insulin?
Yeah, this one happens to be pink, but the insulin's always clear. It's always rapid-acting insulin. And so what you do essentially is you can change the insulin delivery.
Yeah, we should point out, this is largely for type 1 diabetes?
Well, it is primarily for type 1s, but we're now beginning to use them in type 2s as well. It allows us to decrease their insulin dose, especially if they're insulin resistant. So this allows us to essentially physiologically match insulin secretion. Now, these particular models, this one you can see has tubing, and the patient would wear this. There's lots of different ways to wear it, but they can wear it on their belt. This is meant to be the patient's skin, and so this is how it kind of connects, again, with a very tiny plastic catheter. There's also a tubeless pump, and this particular one does have a controller that allows you to make any kind of changes in the insulin dosing.
Did you say neither one of these is linked to the insulin measuring then?
Well, they are, yes.
Well,
that was the point I was going to make next, yes. They are linked, and actually, in fact, at the current time, what's marketed now, they are linked, but it's not what we call a closed loop. However, this spring, the first closed loop, I'm going to explain that. So the glucose monitoring device would say whatever the sugar is. And then what would happen is that the patient would need to then tell the insulin pump, or it would need to be pre-programmed into the insulin pump, how much insulin to deliver. But closed loop means that there is a communication between the glucose that's being measured and the pump, so that it can
auto
tell.
Adjustment
right,
of the
there
amount.
are algorithms in there. And in fact, the first closed loop pump is slated to be marketed. It was just FDA approved recently, and it is slated to be marketed in the spring.
Those are just doing insulin, is that right? These
Yes.
Because I could also see a dual pump, which has insulin and glucagon,
Okay.
and then
Yes.
you can both raise
Yes.
and lower blood sugar
Yes.
based upon what it is.
Exactly, and that's the ultimate artificial pancreas. And I saw some trials on those, and part of the technical issue is that glucagon, unlike insulin, is kind of an unstable hormone. So it's kind of hard to keep in a pump. Mm-hmm. So they got to work those issues out. But I have seen some initial studies of those, and in other words, as we talked about before, if the sugar gets low, then all you have to do is increase the glucagon. So that really works like an artificial pancreas. And some of these prototypes, actually, the only thing the patient has to do is put their weight in every morning, and the algorithms then will calculate how much insulin is needed, which is so amazing, because the current pumps, the patient really needs to be able to do a lot of calculations and be on top of it. But this will eventually, and my prediction is probably in the next few to 5 years, be available, which is going to totally change management.
Yeah, that's it. And maybe preclude the need for some of these drugs because we'll get such tight glucose control.
Well, I think for our type 1s, I think certainly it will make their quality of life a lot better. I think that for many of our type 2s, which is the vast majority of people, we'll still have a need for the pills, for the other medications. And we haven't actually talked about it, but there's also been a number of changes in insulins themselves. So these are delivery devices, but the insulins themselves, and the two main concepts that are coming out now is that the insulin is becoming more concentrated, and the second is that it's lasting longer. So we're able to use these to modify our treatment of patients, to give them fewer injections per day, to more accurately treat the glucoses.
Yeah, the whole idea is to have this work as much like a natural system as possible.
Exactly. And also to make it easier for patients. I mean, we have many patients now that have to take multiple doses of insulin a day, which is difficult.
With blood checks each time.
Right.
So that's it. Let me also ask you a question. There's been this long debate about, is diabetes just simply the absence of good blood sugar control with insulin? And yet we know the effects of diabetes are far-ranging from neurologic damage to kidney damage to arteriosclerosis to lipid abnormalities. Right. With some of these systems that are approximating a natural pancreas, are they able to prevent all these other complications? Is diabetes a simple disease, or is it more complex?
Well, I think the more we learn about it, the more complex we see that it is. I think that's the hope. The hope is that as we more approximate the natural pancreas and the natural insulin delivery, that we will see some of these complications becoming less of a problem. We do distinguish among the complications that you mentioned what we call microvascular complications, which are the eye disease, the kidney disease, and the neurologic, from what we call the macrovascular, which is the heart attack and stroke. And we know from many studies that the microvascular is really helped by good blood sugar control. But the heart attack and stroke, which frankly is the biggest problem for people with diabetes, because that's really what they die of.
And we're running out of time. So 10 seconds left.
Okay, so I guess let me just summarize it by saying that it's an exciting time to be in diabetes right now. We have so much opportunity to make everything better and easier for patients.
Yeah, it's extraordinary. Again, the new drug, the new technologies, the increased understanding. Must be a very exciting time to be in endocrinology.
It is.
And I think great for people at home. It's a common disease that we're making great progress. So I want to thank Nancy, and when we come back, we'll have today's health question. Please write now, take a look at some of the upcoming events sponsored by the Western Connecticut Health Network. Today's Health Talk question is, what is the difference between type 1 and type 2 diabetes? Well, I think we went over that a little bit, Nancy, but maybe you could review again for our viewers at home. What's the difference between them?
Sure. So type 1 diabetes is thought to be due to a problem with autoimmunity, which means the body's making antibodies to the beta cells in the pancreas that make insulin. Classically, it occurs more in children. Type 2 diabetes is thought to be more hereditary. It also is related to obesity, and it is really a matter of not having enough insulin because there's a lot of resistance to the insulin. But to give a more holistic approach, we now have children that have type 2 diabetes, and we have plenty of older adults that develop sort of a classic autoimmune picture. So it's really much more of a spectrum and not just kind of two separate entities. Is
there a way you could say absolutely someone has type 1 diabetes if they get diabetic ketoacidosis or DKA? Does that mean they're type 1?
Well, that is a good way to do it. That's sort of a clinical diagnosis. The other way to do it is to measure antibodies, and there's a few of them that we can measure to determine that. And sometimes we do that when we're not sure.
We've got just a few seconds. Do you ever see a vaccination available that may prevent type 1 diabetes?
Well, that's very interesting. Up until now, I don't think the studies have been that promising for it, and there's been a lot of research. So I don't know.
It's not in the immediate future.
I don't see that, but I guess we can always be hopeful.
Nancy, thank you very much. This was a great show today. Really
Thank you.
informative.
Thanks for having me.
Very, very exciting. So if you at home have a question you'd like to ask me on Health Talk, please contact me at healthtalk@norwalkhealth.org. I want to thank our guest today, Dr. Nancy Rennert, for coming on Health Talk. I will see you next week on Health Talk. Bye-bye.